Hello, everyone. It's a pleasure to be here. My talk today is about how to build better bones. And here are my disclosures. So, what builds better bone? If you were like me, before I went to medical school, I thought bones looked kind of like this cartoon picture here, where just like this rod, this solid mass, and that's all it did. But it turns out that bone is actually very complex. What are the different factors that go into making a bone strong? Are bone mineral density, so how much bone mass there is. And then in terms of the bone that we have, you also want to care about the microstructure, how that bone is arranged. So shown here is a high resolution image of bone. You can see this outer shell that we call the cortical bone. And then you can also see this inner trabeculae in terms of how the bone mineral is arranged. And you want to have a lot of bone and the mineral connected to each other so that makes the bone stronger. The third property that I have here is bone tissue properties. This one might not have come up as much in your reading or in conversations. This is what is the bone material, what it's actually made out of. To better explain that, if you think of an analogy of what goes into making a strong bone, I always think of bridges. Bridges are very much like bones. You don't want your bridge to break if you are walking or driving across a bridge. So, in order for an engineer to make a strong bridge, you care about how big the bridge is. So, that would be the bone mass or the bone density, and also the microstructure. How is it arranged? What's the architecture of the bridge? And the last aspect of a bone tissue property for a bridge analogy would be what's that bridge made out of? Is it made out of wood? Is it made out of steel? Is it made out of rope even? And so all those different factors will go into making a stronger bridge or a stronger bone. So what is osteoporosis? Why do we care about having strong bones? Osteoporosis is the disease of decreased bone mass and strength, and that can lead to increased risk of fracture or breaking a bone. And diagnosing osteoporosis is based on your individual fracture history and or your bone density scan results. Shown here is another high resolution image of bone. On the left here is normal bone. You can see it's kind of thicker. There's more bone or mineral in general. And then here on the right is an image of osteoporotic bone. There's just less mineral overall. And of the bone that you see there, it's thinner and there's less connectivity. So why should we care about osteoporosis? Well, up to 1 in 2 women and up to 1 in 4 men will break a bone in their lifetime due to osteoporosis. And for women, the incidence is greater than heart attack, stroke, and breast cancer combined. And who should be screened? Uh, the universal screening guidelines across many professional societies is that postmenopausal women over age 65 should be screened, and adults over age 50 with risk factors should consider being screened as well. And that's important because women go through menopause in their 50s. Listed here as a result is a list of different risk factors that should be considered for early screening. But I think for you as a patient, the most important information that you can tell your doctor are things that they might not necessarily know, such as if you broke a bone 5 years ago and it's your first time meeting your doctor, or if you have a strong family history of osteoporosis, particularly if you had a parent that broke a hip bone too. So what are the tools to determine fracture risk? Well, your medical history is a major aspect, such as if you've broken a bone before. You can consider having a bone density scan done if you do meet the criteria for screening. Shown here are some images of a sample bone density scan. It's typically comprised of a hip scan of one or both sides and also sampling of your lower back bones. And then other tools to determine your fracture risk are your frailness too, if you're falling a lot. So what goes into a bone density scan? You'll hear it commonly referred to as a DEXA or DXA, and that abbreviation stands for the full name of dual energy absorptiometry. It's a very simple test. It takes about 15 minutes. In this picture here, you can see a patient will lay on an exam table, and this C-arm here that's giving the radiation exposure will rotate over the patient. Now, what are the considerations for the screening exam? There is for some radiation exposure because it is an X-ray. If you put in perspective, you actually get some amount of radiation every day. It's what we call a background radiation exposure. You get it from the sun, you get it from the soil, foods that you eat, and that averages out to about 5 to 8 microsieverts per day. In terms of how many microsieverts you get from a bone density or DEXA scan, it's about the same as if you walk around on Earth for 3 days. A spine scan will have about 7 microsieverts, and a hip scan will be about 5 microsieverts. To compare it to other commonly ordered X-ray exams, A chest x-ray is about 50 to 100 microsieverts, depending on the images that are obtained. A mammogram on average is about 400 microsieverts. And then just added in here for fun, a non-medical fact is a cross-country flight actually has some increased radiation exposure because you're flying closer to the sun. And a cross-country US flight is about 35 microsieverts. So how do you interpret the DEXA scan once you get it? Many of you here in the audience today may have already had a DEXA scan, and you can see the report is pretty complicated. There are two numbers to highlight in particular, would be a T-score and a Z-score. A T-score is what's going to give you the definitions of osteoporosis, and it's defined as the number of standard deviations, or SDs, above or below the average bone density of young adults. And this T-score value is what helps give the definition of osteoporosis. A Z-score is a number that people find of interest. Oftentimes a patient will come in with their report and they'll say, well, I want to see how I compare to my friend, to my sister, someone who's of similar age. And a Z-score is number of SDs above or below the average bone density of an aged matched individual. Listed here are the definitions of the T-score. So it's not here for you to remember the numbers, but just to get a sense of the different categories. Your doctor, once they get the bone density scan, they're going to be looking for the T-score, and they want to see if it's in the normal range, if it's in the osteopenia range, or the osteoporosis. And osteopenia, I always think of it as that in-between range. So something not quite normal, but not quite osteoporosis yet either. So something to keep an eye on, because patients also break bones, even being in the osteopenia range and not yet in the osteoporosis range. Lastly here, it's not a different category, but just to let you know in terms of severity, if a patient is diagnosed with osteoporosis, oftentimes they'll ask, well, how bad is it? And a generally standard accepted definition of severe osteoporosis is if you have a T-score of negative 2.5 or less, plus one or more fractures. I think of a broken bone as really that kind of red flag, a signal of your bones saying, hey, the bones are a little bit more fragile than we would like them to be. And lastly, in terms of interpreting the bone density test, for every standard deviation decrease in the age-adjusted bone density, that was a Z-score, the risk of fracture increases about 1.5 to 2.5 fold, or meaning, in other words, that your fracture risk increases 1.5 to 2.5 times the absolute fracture risk in other women of the same age. Okay, I did want to include in here some new advances in imaging. Many of you have also come across this idea of TBS, or trabecular bone score. And what it is a measurement derived from a standard two-dimensional DEXA spine image. And what it's doing is it's assessing how variable the distribution of the image is. So if you took a standard spine X-ray image, like shown here, and you pixelated it, put it in different shades of gray, you're trying to get a sense of how uniform that structure is. And the idea is that TBS correlates to the microarchitecture. Shown here is an illustration of TBS where you have a bone density or a BMD score that's higher at 0.972, but the T-score is 1.459, which is okay. And then you can have one where the bone density looks pretty good, 0.969, very similar to the top value, but their TBS is actually lower, suggesting that they have worse microarchitecture or a lower TBS value. In terms of how we use that clinically, not all bone density centers have TBS available yet, but I know many centers are working on that, but it's best used to help you more accurately predict if what your fracture risk prediction is over the next 10 years. This is a very busy slide. It's a fracture risk calculator for patients who are diagnosed with osteopenia. That's that in-between category. And what your doctor can do is they can go through this yes, no, or this 12-step information checklist, and then it will give you a predictor of what is your probability of fracture over the next 10 years. And then you can also add on top of it that TBS, or trabecular bone score value, to adjust it to make it a little bit more accurate. So that would be my recommendation of the best way to use TBS, as it's the most validated way clinically at this time. Okay, so we're about halfway through, and what I really want to focus on is the title of my talk is saying, okay, well, what goes into building a better bone? And this is a pyramid that I have just drawn for myself. I like to do it with my patients when we're in the office together. I do want to say the effect of the possible interventions are not to scale. It's just to help our conversation today. But I really think of it as the foundation is fault prevention. We'll go through that in just a minute. The next tier I think of it is our lifestyle interventions. So things that you could control. So in terms of your diet, your exercise. And the last tier is a prescription. And that's if it's recommended by your doctor. But the main reason why I always like to go over this illustration here is really to emphasize, I don't feel that bone health treatment should be picking one or the other, saying, okay, it's a new year, I'm going to really focus on my exercise, or, oh, next year I'll really focus on my calcium intake. I really think that they're all working together and they're building together to help improve your bone health. The other aspect you might notice of this figure right here that I've drawn out is actually think of it for all patients. It's not just for those who have already been diagnosed with osteoporosis. I think it's great for general bone health too, and preventing bones from getting worse. Okay, so the first aspect here, as I said, the foundation of the pyramid is fall prevention. I have here a checklist of some common things that your doctors might talk to you about, probably things that your family has talked to you about too, kind of common sense things to help prevent falls, particularly in the middle of the night. And also I have a website. You'll see in just a couple of slides at the Bone Health and Osteoporosis Foundation, they have a much more comprehensive checklist. But again, what I always say to my patients, the most common sense thing is if my goal is to help you not break a bone, if you just don't fall, that's the most important thing you can do for yourself. Nothing I can recommend or prescribe will be any better than if you just didn't fall in the first place. So it's really a priority to look around your everyday surroundings, your habits, and see how you decrease that chance of falling. Next is exercise. That's always a commonly asked question. What's the best way to exercise? And you really want to focus on a weight-bearing exercise. That comes out to pretty much everything that you're doing. I would say some physical activity that's less weight-bearing would be swimming and cycling. So if you enjoy doing that, that's fantastic. Still work that into your exercise regimen. It's great for other non-bone health reasons. It helps with your cardiovascular health. But I wouldn't make it your sole exercise if that was your goal of focusing on your bone health. And I really recommend you want to do what you love, because this is building a foundation of lifelong habits for exercise that you can do consistently. The goal would be about 30 minutes a day, 3 to 4 days a week. I do recommend avoiding certain postures such as forward bending or a set and twist. So anything where you're leaning forward and picking up something heavy that can put a lot of strain on your backbones. That's general recommendation, so you can avoid straining your back muscles as well. But that's particular for bone health. And then if you need to, particularly if you're concerned about frailty or increased risk of falls, then working with a physical therapist is a great idea, and you can get a referral from your primary care doctor. Some other online resources, as I mentioned, there's a website I love to direct my patients to. It used to be called NOF, for National Osteoporosis Foundation, and they're now renamed to the Bone Health and Osteoporosis Foundation. As an excellent resource for lots of handouts on exercise, and also that checklist that I mentioned for fall safety as well. Now, the last major topic I wanted to cover is the dietary goals. Again, this is focusing on that second tier of my pyramid. What can you control? And part of it is getting enough calcium and vitamin D. These are the two supplements I really focus on the most. There are oftentimes I get questions. I'm happy to take questions during the Q&A of other supplements, but I really want to focus on the basics. So recommend you get a minimum of calcium, about 1,200 milligrams a day for postmenopausal women, and vitamin D about 800 units per day. Now, how can you achieve that? This 1,200 per day I recommend getting from food and or pills. So you want to start with saying, okay, well, what do you normally like to eat on a daily basis? And let's go through it. So the calcium pills is an option too. The most common types you're going to see are calcium carbonate or calcium citrate. And I have here listed a lot of extra information if you want to go back through and pause on this just for your reference. But really it comes down to these are the most common types that I would say that you see in the store. A common myth is that calcium citrate is better. If you do have some kind of condition, say where you're taking an acid blocker for heartburn, I do recommend calcium citrate because you can absorb it better. But if you don't have that condition and aren't taking those medications, calcium carbonate is perfectly reasonable as well. You do want to be cautious in terms, or not cautious, but more just careful when you are checking the labels of the calcium pills that you're buying. The trickiest part is sometimes the serving size will say 2 tablets and you're only taking 1. And so you're getting half of what you thought you were getting. And then you also want to check how much elemental calcium is in the serving. So on the front, you can see here, common brand here, it says, oh, ultra strength 1,000. So you think you're getting 1,000 milligrams of calcium in one tablet. But in reality, if you turn around and look at the label, one tablet would actually only have 400 milligrams of elemental calcium. So just to be careful with that. In terms of how to read a nutrition label, I had started to say what you want to start doing is taking a look and seeing what are the foods that you enjoy eating on a daily basis and checking the nutrition facts. Again, double check the serving size and then take a look at the percentage. If it gives you a percent and it doesn't give you the absolute number in milligrams, what you can do is just multiply that times 1,300. That's because the US RDA has it recommended as 1,300 milligrams for adolescents. And you do the math of 0.45% or 45% times 1,300 is 585 milligrams. I did include here a slide as an update of creative dietary sources of calcium for all diets, as I know many patients don't tolerate lactose or just don't enjoy it. There is a long list of milk products that this is not exhaustive, but I have to say I actually enjoy trying all of the different ones. So you can kind of go through and play with that as you do your grocery shopping. Regular milk is just fine. I often get asked, is there a preference between whole milk, 2% skim? From my perspective for bone health, they're all okay. So it just depends on your taste preference, or if you're trying to avoid fat for reasons, then you can select 2% or skim milk. Other alternative milks are almond milk. That one tends to be very highly fortified. Certain brands will have it as much as 1 cup of almond milk will be 450 milligrams. So it's just a matter of checking the labels. And then there's a whole host of other alternative milks: soy milk, oat milk, cashew milk, rice milk. There's even plant-based ones of pea milk too. And then some other foods that you can consider if you can't tolerate dairy products or almonds, tofu. And then some products are just calcium, they're fortified. So products such as orange juice, certain cereals, if you look at the label, breakfast powder mix, like a carnation mix is a common one, or even some hot chocolate mixes. So you can get creative once you start looking at the nutrition labels. The last tier that I have here is the osteoporosis treatment. And what I do want to emphasize is that the current osteoporosis medications, they reduce the chance of a broken bone, anywhere from actually 30 to 70%, depending on which bone that you're looking at, but none of them cure osteoporosis. So if you're already been diagnosed with osteoporosis, whether it's based on your fracture history and or your X-ray DEXA results, keep in mind that this will be an ongoing conversation with your doctor. There are many FDA-approved treatments for postmenopausal osteoporosis. The two big categories, I would say, are anabolic, or medications that kind of, quote, unquote, grow your bone. And then there's also anti-resorptive medications. And these ones, they help slow down the bone breakdown. There are pros and cons to both sides. As a big overview, I would say kind of the easiest things to keep in mind for the anabolic category. These first two here are daily self-injections. This third one here, I have an asterisk because it actually is dual mechanism, where it's uniquely both anabolic and anti-absorptive. But this one involves monthly visits for a year that are clinic visits to see the nurse at the clinic. And then this column here for the oral for the anti-absorptives, there's pros and cons for each medication. So it would be up to a very lengthy, detailed conversation with your doctor about what would be the best choice for you. I do want to include one note here that estrogen or hormone replacement therapy, it is FDA approved for prevention of osteoporosis. It's typically not considered first line as sole treatment for osteoporosis as the only reason to be prescribed estrogen, but it's a great option if you're considering being on estrogen for other reasons. If you're experiencing other major postmenopausal symptoms and your doctor thinks that you'd be a good candidate for estrogen, it's actually nice to know that estrogen is really good for bone health as well too. So to summarize, I really want to emphasize that lifestyle intervention, it's the foundation of your bone health, whether you've already been diagnosed with osteoporosis or you're looking to help prevent it. I do recommend seeing your doctor for ordering at least a baseline initial screen bone city scan after age 65, or consider even earlier after age 50 if you have certain risk factors. And after that point, if you've had your DEXA scan and you haven't been diagnosed with osteoporosis, that's great. It depends on what your starting results were in terms of how often you should get a repeat screen bone density scan. Commonly, it would be as early as 1 year. Most of the time, it's going to be 2 years or more, though, depending on the results. And lastly, if you have been diagnosed with osteoporosis, it would be a careful discussion regarding the prescription of medications, keeping in mind that none of them really cure the osteoporosis per se. So it might be a course of ongoing off and on cycles of therapy throughout your life. And I just want to thank you for your attention, and I'd be happy to take questions during the Q&A portion. Thank you so much.